Let's talk about appendicitis. 5% of the population. That's a pretty big amount. Okay, so acute inflammation of the vermiform appendix, located off the proximal cecum of the colon. I did have some pictures earlier for you guys in the very beginning in part one. Know that this is really important. Gangrene can occur within 24 to 36 hours. Perforation may develop within 24 hours. So here's a picture for you. Here's your large intestines, there's your cecum, and there's your wonderful appendix. Okay, that's the picture I had for you. So let's talk about some risk factors. I know it started with young male, so risk factors, but remember, both sexes do get appendicitis. Here are some of the manifestations. They're going to have some abdominal pain, then the nausea and vomiting comes on, but they start having a lot of abdominal pain, cramp-like pain. So sometimes they even have that epigastric or the periumbilical area pain. So when you're doing your assessments, look in the periumbilical area and see if they're having pain over there. Inflammation shifts. Where is it going to be? Right lower quadrant. McBurney's point. Okay, so look at the McBurney's point. If you guys not familiar with that from your regular physical assessment, please review McBurney's point again. If pain is relieved when bending, right hip or the knees could signal perforation. So these are things that we should know about appendicitis and what different body movements take place. Of course, the rebound tenderness. In your chapter, it does talk about rebound tenderness. These patients are going to get a CBC done. We're going to check and see if that CBC is elevated. And they're also going to get a CT and an ultrasound done also. Some of the complications, we're going to look for ABCs, right? With the anesthesia, because some of these patients will go to surgery. Same as with any surgery. So you're gonna, ask for consent, right? Some of the appendicitis, when they go to surgery, it's same day surgery. They have the surgery and they go home. Before it used to be they stay in the hospital for extended amount of time. Let's look at peritonitis. It is life threatening. Can you imagine if we go back to this picture here? Not really a good one to show you, but if that appendix rupture, your cavity sits in a very thin lining of fluid. So that means it will get infected with all of the byproducts that are in the appendix when it ruptures. So that's why it's life threatening. Most often it's caused by contamination of peritoneal cavity by bacteria or the chemicals. So know that that can happen. Appendicitis, diverticulitis, peptic ulcers disease, gangrene, gallbladder, and bowel obstruction. A lot of these things do happen with our patients. So peritonitis, what are some of the manifestations? Here we are. I'm not going to read them all to you, but look what's in red. That rigid board-like abdomen. So how we were talking about over here, where we do our assessment. Oh, I'm sorry. I was trying to go back to the slide where we talked about the legs, and you can tell different things like the rebound tenderness and so forth. I want to say it was over here. Here we go. So don't forget about this slide. It kind of tells you like it can signal perforation or peritonitis, right? So then when we go back and talk about peritonitis more and the manifestation, look at what's in red, that board-like abdomen. Look at all of it also, but also including your assessment, what could happen. So here's some treatment that can happen. For sure these patients are going to be put on antibiotics. They're going to put on IV fluids. Also, they need to decompress their stomach. So NG tube, they will be NPO. They will get something for their pain. And then, of course, surgery or a surgeon is going to come by for a consult to see if these patients are a candidate for surgery. So peritonitis, surgical management. So this is what happens. So they're going to just basically take out the fender. What is it that's causing the peritonitis? That's what's going to be removed. So now as we move forward, we have gastroenteritis. So that's the inflammation of the mucous membranes of the stomach and the intestinal tract. A lot of these patients come in also nausea, vomiting, diarrhea. It's been going on for a little while. That gastroenteritis can be caused by several things. Gastroenteritis, we will see a lot of this in the acute care setting. So it is inflammation of the mucous membranes of the stomach and intestinal tract. Patients will come in with diarrhea, nausea, and vomiting. It can be associated with viral or bacterial, usually self-limiting. Sometimes you can just, with your assessment, you can ask, have you been on any recent travels? What did you eat last? Has anyone around you been sick? And so forth. So your gastroenteritis manifestations, like I said earlier, the nausea and vomiting, but pay attention. There is no rebound tenderness in gastroenteritis. That's your API you're looking at. Patients with the nausea and vomiting, because of the nausea and vomiting, diarrhea, they're going to experience some dehydration. Here are some replacements that you guys can read here. So for sure, some IV fluids, some antibiotics, okay, and some information or medications that they'll get to help slow the GI track down, that motility. Inflammatory bowel disease is a GI disorder with no known etiology. So what I was trying to tell you guys today, I wanted you to read on ulcerative colitis, and I also want you to read on Crohn's disease. So it's very important to know them. So ulcerative colitis is a widespread inflammation of the rectum and the rectal sigmoid colon. So please know that difference, okay? They do get remissions, and sometimes the patients think it's all over. I've experienced that. Diarrhea and some bleeding. It's all over, but they're probably in remission. And so they could have an exacerbation of ulcerative colitis. So some of the complications that these patients have, they do have some of the management that they do is some patients do non-surgical rest, hydration, pain control. So just rest, hydration, pain control. Sometimes the doctors even put them on NPO for a little bit. And then some of the drugs, and here are some of the drugs that they do use. Okay, let's keep moving forward. So the surgical management, and here we go. Here are some of the videos I wanted to show you. Some of these patients, they do have the colectomy, they do have the ileostomy done, and the wound care. I would like for you to, I'm not going to open up each of these videos, but these are very good videos for you to watch. Remember I told you about NPO, patients sometimes get the, have the NG tube also to help with the decompression also. And then, of course, as nurses, we're going to do our interventions as monitoring the intake and the output of the patient. I would like for you to watch these videos. I did post them in the announcements too. If you like, I can do it again, but the videos are in the announcements. So let's talk about Crohn's disease. So when I asked everyone, hey, what did you read about on Crohn's disease? And everybody was so quiet. So let's look at Crohn's disease. Inflammatory disease of which bowel? Is the small intestines. It's mostly involved. Okay, so colon or both. But most often it's the small intestines. It's slow, progressive, recurrent. They do have that inflammation of the bowel wall. They do end up having some strictures and deep ulcerations occur. They do have the severe diarrhea. So malabsorption of vital nutrients too, because nothing is staying in, it's just going straight out and it's not being absorbed. So Crohn's disease, it can be genetic, immune, environmental factors, they do cause Crohn's disease, but exact cause, really people don't know, but they can just state different things that has happened with patients. Uncontrolled inflammation of the intestines. So you have all that inflammation. So smoking and bacteria contribute to the disease also. So look at those, and these are things that we can start teaching our patients about. So when we start teaching our patients about it, we can, mention to them there is non-surgical things that can be done. So they can use some drugs. The doctors can put them on antibiotics for those fistulas that occur. They can go on immunosuppressive therapy, of course, nutritional therapy because they're not absorbing what they need to, hydration to keep them from being dehydrated, and also pain medications for pain control. Now, they do have the surgical things that can happen for those who have not improved after all that medical management that was going on that we just talked about. They do have surgical. Okay, so these are things that can happen. So if we look at gastritis on page 111 of your 9th edition of your book, in chapter 55, it talks about gastritis. It is an inflammation of the gastric mucosa. So here's some things that can go on. There's different types. So in your book, it has each paragraph, one about chronic, one is concerning acute, and atropic. Okay, so let's talk about acute. So acute gastritis is an inflammation of mucosa or submucosa after exposure to an irritant. So the thickened red and mucous membranes, prominent folds, various degrees of mucosal necrosis and inflammatory reactions happens. And then some of the causes. Have you guys heard of H. pylori? That's an organism that's found in the colon or in the GI system. So long-term use of NSAIDs. So that's some of the causes of gastritis. And of course, these things also. So let's continue on with chronic gastritis. So we just talked about acute. So now chronic gastritis. Look at all these symptoms here. Look at right here. Function of the parietal acid secreting cells. We talked about those. Decreases and intrinsic factor is lost. So B12 absorption. So guess what's happening? Pernicious anemia occurs. So remember we talked about which one of colon's, we talked about, what did we talk about? Absorption of vitamin B12. So we don't get that vitamin B12, pernicious anemia is going to result. Okay, so also you have that increased risk for gastric cancer too. So here's our last one. So it's kind of like a type of chronic gastritis, really. It's seen most often in an older population. So it's caused by toxic sepsis exposure. And then sometimes, H. pylori, the doctors will put the patients on antibiotics, it'll resolve, and then it comes right back. So here are some of our assessments, that we will see among our patients. So for chronic, so EGD with biopsy is the gold standard for diagnosing gastritis. EGD. So they go down and they see inflammation, irritation, all those things with the endoscopy. So here are some of our interventions for acute and chronic gastritis. So prevention and education. Let's talk about prevention. So education, we're going to teach the patient to read all over-counter drugs labels to avoid aspirin or NSAID. So we have to make sure we reinforce that. You limit the intake of food that cause stomach distress. So spices, things that they know particularly for themselves. High acid content, tomato products, citrus juices, all these things. So each patient is different, but sometimes you find things in common that happens to each of them. So they need to keep a diary and understand what is it that triggers gastritis for them. I didn't want to go over all the drugs, but on page 111 of the 9th edition, chart 55-3, you will see a list of the medications, okay? So let's talk a little bit about peptic ulcer disease. And we'll talk about that on the part 4, because we have less than a minute and there's no way that we're going to get through peptic ulcer disease. Okay, I'll see you in part 4.